Welcome to the DaVinci Hour, a podcast series that interviews individuals across the field of medicine to help provide an inside look into their experiences and provide insight on how to navigate the journey of becoming a physician. My name is Dr. Maxwell Cooper, and I will be your host. This podcast is brought to you by DaVinci Academy, a medical education company that provides online video courses, outline format books, and clinical case videos for students studying the medical basic sciences. You can check out all that DaVinci Academy has to offer at www.dviacademy.com.
All right, everybody, welcome back to the DaVinci Hour podcast. This is our 10th episode, and for this, we've got a great guest, probably my longest time mentor in medicine, Dr. Joe LaHora. I'm very excited to have Joe on the podcast here. He's generously given us his time. A little background on Dr. LaHora. He's the chief of cardiac surgery and then the chairman of the Heart Vascular Institute at the Cleveland Clinic, Akron General Hospital in Akron, Ohio. He started his career at Tufts, where he got his bachelor's, and then he got his MD from the Johns Hopkins University School of Medicine, did his general surgery residency at University Hospitals of Cleveland, Case Western Reserve University at Cleveland, Ohio. And then he did a 2-year research fellowship during that time at Mass General Hospital in Boston for cardiac surgery, and then did his cardiothoracic surgery fellowship at the University of Michigan. So Joe, great to have you on. Welcome.
Thanks, Max. Thanks for asking me to do this. This is a lot of fun. Yeah,
Awesome.
You and I, we go way back. I remember when you were rotating as part of your senior high school project. On our service, we had you in the OR, and then you kept coming back. You never left.
That's
and
right.
It was fun for me. It was great. We had a good time, and I really enjoyed those days an awful lot. We had some long days together, and it was fun to be with someone who enjoyed being there. I was excited, interested, and smart, and had a great sense of humor. So those were really good days.
Yeah, no, go ahead. Yeah.
No. So it points out to me that, when you were with me on the service, it makes you think about your career as a cardiac surgeon, like why you went into it.
Mm-hmm.
Makes you think about what you're doing, and because you're teaching someone who's interested and trying to give them perspective on the field and what it's like at a professional and personal level. And so it was very good for me. I mean, it was good for you, because you got to see a lot of cool stuff, and you got to learn a lot about heart surgery and about medicine practice. Is good for me because you have to teach someone and think about what you're really doing, and so it was very beneficial to me as well.
Yeah, no, I look very fondly on those days. That was my first real intro into the world of medicine. And obviously to this day, it still inspires me to keep going and what I do today. And so, yeah, definitely. And I think one thing when I think back on that is just how much impact you can have on patients' lives, like through clinical care and,
Right.
specifically cardiothoracic surgery too. So I think, I gave a little bit of your bio. Maybe tell us about your current position, like kind of what type of patients do you see? What type of pathology do you see? Like what are your typical like procedures and things like that?
So I do adult cardiac surgery. I do adult thoracic surgery as well. Some adult thoracic surgery, but I primarily do cardiac surgery at this point. So I treat patients, care for patients who have usually acquired disease of the heart, some congenital disease of the heart, but mostly acquired disease of the heart. Coronary artery disease is the preponderance of what we see. Obviously, very prevalent in American society. Surprisingly prevalent amongst young people in American society, with obesity and diabetes and smoking and all these lifestyle habits that predispose to vascular disease. But also do a lot of valve work, aortic valve work. For aortic stenosis, a lot of aortic stenosis, both senile calcific disease as patients get older, but also a lot of bicuspid disease, patients who are born with bicuspid aortic valve predisposing to aortic disease, mitral valve disease, a lot of degenerative primary mitral regurgitation, some secondary mitral regurgitation. In the past couple of years, the opioid pandemic has sent us a lot of endocarditis patients who have valvular disease, a lot of that, the tricuspid valve, mitral and aortic valves, and then also aneurysm work, some arrhythmia work with for atrial fibrillation, a number of procedures for that. Many combined, concomitant procedures, patients have aortic disease and coronary disease and atrial fibrillation.
Sure.
So that's primarily what we treat. I think probably the most important part, the most important development over the past few years for me, when I look back at when I started off and where we are today, and that is the importance of a heart team approach to the care for these patients.
Mm-hmm.
So when I started off, I have to be honest, when I started off, you get a call from a cardiologist that I just capped someone in a cabbage. They're in room 402. Thanks, bye. And you would go see them and tee them up for surgery. And there wasn't much discussion about it,
Mm-hmm.
That's just not a very good way to do things. And looking back, I was like, this wasn't a very, very thorough approach to things. Today, we have a heart team approach where I work very closely with, first of all, other cardiac surgeons. We're not in silos, working totally independently or at worst competing against each other. And we work very closely with interventional cardiologists, general cardiologists. We're part of the evaluation and decision-making process. And then also increasingly, as we work in structural heart realm with aortic and mitral valve disease, and especially now also as TAVR, the catheter-based aortic valve replacements have become very preeminent. We're looking at, we need a cardiac imaging specialist. Mm-hmm. So cardiac imaging informs us tremendously now. So in my practice, I don't really evaluate patients in a solo sort of way. We meet weekly to review just virtually every case. First, certainly difficult cases, but virtually every case to decide mm-hmm. what's the best strategy for dealing with a particular coronary anatomy or a particular valve problem. So yeah, we work as a heart team and determine the best course of evaluation, the best course of treatment, and even our clinic with the TAVR technique, the catheter-based valve implants that are now done. Patients have to decide. We work together to decide what's the best approach to replacing the aortic valve. Is it surgical aortic valve replacement or catheter-based aortic valve replacement? And so we have a joint valve clinic now. So it's staffed by myself and other cardiac surgeons and interventional cardiologists, and our nurse practitioners, and patients are seen by us simultaneously.
Wow. And
evaluate simultaneously, and then we have shared decision making with the patients.
So it's truly like a multidisciplinary approach now.
Yeah. So
it's pretty cool.
So using aortic valve disease as probably the preeminent example, they get referred to us and they're seen in their clinic by the cardiac surgeon, the interventional cardiologist, and their nurse practitioners, and then whatever workup is done or is recommended, and then the data goes to a valve committee, which comprised of many of us, and the case is reviewed and decision making is decided upon, and then the procedure is done jointly by a cardiac surgeon and an interventional cardiologist. So this is truly, very collaborative, and I've found it to be incredibly beneficial and very gratifying. So, I've learned so much from working, directly with my interventional cardiology colleagues. We're working with imaging specialists, and our understanding of valve disease and the various interventions is so much more detailed and in depth than it ever was. And I really can't imagine practicing it any other way. I think the other benefit to this or aspect of it is that we are all functioning as a heart team, and there's no competitive interest that skews our decision making. it really is what's best for the patient, and evidence. We try to be as evidence-based as possible. And I think patients really appreciate that when they see, their doctors and the nurses working together and coordinating. So that's one big change I've seen over the years since I first started out. And I would say too, another aspect of things that has changed is we work very, obviously we're primarily concerned about patient safety and outcomes, making sure that patients get the very best care. And that involves a lot of, optimization now of patients, which was when I first started out was not really, on our radar screen. It's like, you kind of assess them for other things that might make them very high risk for surgery. Today, we spend a lot of time evaluating patients and optimizing them for surgery, trying to minimize the things that we know are bad for patients, like, transfusion, trying to optimize pulmonary function, nutrition, mobility. And that involves a lot of protocol-driven assessment and care, which a corollary of that is the importance of checklists in maintaining safety in cardiac surgery. So that's another evolutionary thing in cardiac surgery. Have you read Checklist Manifesto by Gawand?
Yeah, I think I have. Atul Gawande. Yeah.
So that's a very important aspect of what we do. I often, when I'm talking to patients and talking about risk, one of the most important things a cardiac surgeon does in talking to patients is assessing risk. What's the risk? What are the indications for a procedure? What's the risk? How do we just discuss that with patients? And so I try to assess risk and accurately communicate to patients what the risk of surgery is. Fortunately, today, risk for most patients is very low. And part of that is because of the multidisciplinary approach to the perioperative optimization, and then protocol-driven care that aims at achieving evidence-based guidelines and interventions and processes. And I can tell you with those important themes in cardiac surgery, and I think in surgery in general, we've been able to achieve some really great things. Today we are able to offer cardiac surgical care to patients who need care and get them through some big operations and some difficult times with fairly low risk and very good outcomes. And that's important because cardiac surgery by its nature, you're dealing with a vital organ and patients who can be very ill, and there is the potential for very serious complications, life-altering complications, or death, sometimes very unpredictably. And so those components, I think, the fact that we work together as a team, we try to optimize patients, we have protocol-driven care, looking for highest quality. That is that's been able to drive really good outcomes. I think too, from the personal satisfaction standpoint, I tell you what I have found both the most powerful thing in my practice and the most powerful thing in terms of getting good outcomes and patient satisfaction is functioning as a team. Cardiac surgery is a team sport. You can't do this without a team of people.
Absolutely.
But if you're not functioning as a team, it's just not gonna go as well. So that's one thing in my role as a leader in cardiac surgery and now more recently in a department, what I found very satisfying is the effort to put together teams of people, highly motivated people who work together well as a team, who are interested in best outcomes, And one of my greatest satisfactions is taking, particularly advanced practice, nurse practitioners and physician assistants, and also junior staff, and giving them responsibility and goals and the freedom to move things forward. That's very satisfying.
We're going to take a quick break to let you know the DaVinci Hour podcast is brought to you by DaVinci Academy, which provides online video courses for the medical basic sciences. These courses are taught using a variety of teaching methods, including bullet point outlines, diagrams, radiology images, and chalk talks to explain the fundamental concepts. We then teach the application of those concepts to numerous clinical pearls that are frequently tested on medical school exams and the USMLE. Our video courses are available on our website, dviacademy.com, as monthly subscriptions starting at $9.99 per month. Each video course has a corresponding outline format textbook as well. You can find the link to our website in the description below. Also, be sure to use the discount code TDH20 to receive 20% off any of our video courses. All right, now back to the podcast.
So anyway, that's what do I do every day?
Yeah, I guess maybe just walk us through like your typical inpatient day, like when you have like surgical cases, like when you round, stuff like that, like what time do you get there?
So I start early. I don't live in Akron. I live a bit away, so I get there a bit before 7, like usually about 6:45, and I have typically I have a case to do. Most days I have cases. If it's not my office day, I have one day a week, which is an office day. I go and we meet the patients in the pre-op area. We do what's called a huddle, which is a safety protocol. So we meet the patient, the anesthesia team, assisting team, the perfusion team. They're all there. They meet the patient, and we go through the play of the day. We make sure that all the essentials, all the quality indicators are met, to make sure that they've had their aspirin, their beta blocker, the blood's available, that the devices are available. We know exactly what we're doing, that everyone's questions are answered. It's an opportunity for anyone to speak up and say, what about this? Or we forgot this. So that when we go back to the room, there's no question about what's going to happen. We do the huddle, and then the patient gets taken to the operating room, and at that time, anesthesia gets their various intravenous lines and monitoring lines going. They don't need me around for that. So at that point, I will either go to a meeting, like the heart team meeting, which is from around 7:15 to about 8:15. Usually by then, the patient's ready for me, or make my quick rounds through the unit with our nurse practitioners and PAs to make sure everyone is moving forward. Look at the previous day's cases and that sort of thing. So then I get started on the case. And again, it's a team effort. I do the sternotomy and cannulation for cardiopulmonary bypass and harvesting of internal mammary arteries, et cetera. And the really talented physician assisting team gets going on harvesting either vein graft or radial artery graft or both. And I like that. I mean, I have these are advanced practice people who are practicing at the top of their license independently. They do things I cannot do. I can't harvest endoscopically. I don't know how to do that. So I have to have them do it.
Yeah.
And you have to have the right people for it, and you have to attract the right people and keep them on the team and keep them happy. And we try to do that by, as I said, by giving them a lot of leeway and responsibility.
Sure.
So those cases typically, they're long cases. They're not, heart surgery is not quick. It's several hours, depending on how things go. So we get going and we get on pump and we do our work, and then we come off pump and close up. And again, I work very closely with anesthesia in this in terms of making sure that, we do that everything is looking good. We do intraoperative echo on everybody, make sure the heart functions good, and we check the grafts, make sure those are flowing, make sure the valves we put in are working. We make sure that there's no surgical bleeding, make sure they're ventilating okay, et cetera, and go through again, checklist. I sign out, our team, and then they go to the intensive care unit, and there we check We do another checklist again at the bedside
Mm-hmm.
to make sure that the team receiving the patient knows what's going on.
Sure.
That's a big game changer too. I can tell you, when I first started in practice, we'd drop the patient off in the ICU and you take off and go do the next thing. And you get calls all night and there'd be questions about what's going on. But we do a formal sign out where the nursing staff receiving the patient knows exactly what's going on, and what's going on. And most of those patients, when I started in practice, patients that had heart surgery were usually intubated all night. They were kept sedated.
Oh, really?
Oh, yeah.
That's
That was
crazy.
the remark. It was crazy. Yeah, they were intubated all night. And the next day you come in, tell them, okay, go ahead and wean. Today, we have protocol driven. They're extubated in just a couple of hours, and they're very quickly. And this is really beneficial. This has changed a lot for patients.
Wow.
So yeah, we move quickly. They're extubated quickly. The next day, most the lines come out, and when the day the chest tubes come out, and they're out of bed into a chair by the next morning, and they're walking the next day, up and moving, and hopefully home within about 5 days. That's the goal.
That's pretty amazing. I mean, for operating on such a critical organ and somewhat invasive procedure to have someone back where they came from in 5 days is pretty amazing.
It amazes me too. But I think that what's impressive about it is just it's a whole team of people working together, and you have all these protocols in place, and you just have to make sure they're all being paid attention to. I often look at it like you're flying a plane, and I think Atul Gawande, some of the checklist manifesto came from the fact that, there are millions and millions of passengers flying every year without any deaths.
Mm-hmm.
That wasn't always the case because they've introduced checklists into the airline industry. They're very careful, and we've emulated that. And but I look at this the same way. Like when I look at a patient and trying to assess risk, I want to make sure before we take off that everything's working and everything, we know where we're going, and we got enough fuel, and we have everything we need. So I look at that as like the last check before you run down the runway. And then same thing when you're landing, you got to have everything ready to go, and what you're doing. And it results in amazing things. I mean, people come in who are very ill and who are looking at the prospect of heart failure or death, and it's very gratifying to take them through that path and get them to the other side. And I find I would say that if I was to say what's my biggest satisfaction doing this, I think that's it. I mean, to have a patient, to take someone successfully through that and see them recover and doing very well, and that's very, very gratifying, because there are some really sick people that we help to get back to normal life or relieve their suffering. And then the other thing, as I mentioned, the team aspect of this is it's one thing that drove me to cardiac surgery was working as part of a team, doing something critical. It's not minor stuff. I do find the life and death aspect of it, although it can be very tense sometimes, and it has its emotional toll at times. I think that's something that I find very important to me. And there's also a technical aspect. I mean, I like doing the technical part of cardiac surgery. I mean, I like it's very fine work, and it's very technically dependent. You have to do a technically competent job, and your outcome is very dependent on your technical competency.
Sure.
So that's a challenging thing too, and it for people that are considering that career, have to think about that. It takes time to develop that technical competency.
Sure, that's why the training
doesn't just come, yeah, right. It doesn't come overnight, and you have to. It takes time to do it. It's like anything else, you can't, and no one is an automatic at it. No one, you got to develop it over time.
Sure.
And you're always learning. I mean, this. You're always learning.
Right.
Nothing stays the same, and you come out of your fellowship and you think you know everything, think you've seen everything. It's like, no. Like within a day, you're like, I've never seen that before. What do I do now? Well, I don't know. I don't know what to do. It happens to me still. Like I've been doing this for 25 years, and I still have things I've never seen, don't quite know how to handle. But that makes it interesting. It's if we did the same thing every day, it'd be very dull. That's one thing that we find funny. Heart teams find funny because there are other surgical specialty teams are like, why do you want to do that? It's like the same operation all the time. Like just do a bypass. Like no, every single one is totally unique. I think you remember that too. Like
Oh yeah.
Yeah. Everything is a unique situation, and so to say that it's this, that's repetitive, I think is really just don't understand what we do.
No. I mean, people's anatomy are different. People's comorbidities are different. Everything. Yeah.
Strategies, the revascularization strategy is different. It's always a unique situation.
Sure. So how's your favorite day of the week? And I say that jokingly, the office day, your clinic.
Well, my clinic day, I know what you're talking about. Like it's when if you were to compare operating to clinic day, I mean, operating is a whole lot more fun than clinic day for me.
Sure.
Because clinics are always just you just talk a lot all day. And
the
thing I don't like that I find difficult about clinic, I don't like about clinic is that you have to make some decisions fairly quickly. Patients come to you and you have to synthesize data very fast and come up with some kind of plan very fast. When patients are inpatient, you have time. You can see them and go, hey, we'll get back to you. So I like to think about things, cogitate on things a little bit. And in the office, it's hard. You don't have time to do that. There's a time pressure. People are waiting. If you keep people waiting, they get annoyed. But I think, I still enjoy talking to patients and seeing patients in the office and formulating a plan. As I said, I particularly enjoy our valve clinic because it's a collaborative clinic. I mean, we are constantly teaching each other and discussing and debating cases, and I like that. I like working with another brain in the room, and we look at imaging together. We have this big screen monitor on the wall, and we pull up the echoes and the caths and review all that stuff. But one thing I found very important in office is the it's essential to have advanced practice help. So when I do office, I pretty much see all new patients in office.
Okay.
New consults with my nurse practitioner. And as we're finishing up our discussion, the nurse practitioner helps to get everything ordered and referred and gets the ball rolling. And then they also do all of our follow-ups. The post-op follow-ups are seen by our nurse practitioners. It's pretty standard visits at 1 week and about a month after surgery.
Okay.
And if they have an issue that they feel we need to address, we take care of that as well. But that's at my phase of my career where I'm busy operating and then I have a lot of referrals on my office days. It would be impossible to see all the follow-ups as well. It just would be too much office time.
Sure.
And so it's not like vascular surgery. Vascular surgeons end up, I think, seeing a lot more of their long-term post-op patients, and it's more of a surgical and office-based practice. Cardiac surgery weighs more heavily towards an operative practice, with office being sort of thrown in.
And are a lot of these patients, are they referred to you by like people's PCPs or cardiologists, or I guess how do they find their way towards you typically?
So the vast majority is seen by cardiologists before they get to me.
Okay.
The vast majority is very rarely a PCP. Sometimes a PCP will have a finding on a CT scan or an echo that they ordered.
Okay.
And just say, go see your heart surgeon. And that's not like the correct sequence. Like you would prefer to have them seen by a cardiologist. But it works out. Sometimes that's appropriate, but mostly it's cardiologists who have seen a patient, and we know that they have coronary disease or valve disease or heart failure or arrhythmia issues or aneurysm issues, and they get referred to us, and we see them there. So that most of them come by that route.
Gotcha.
And then we have to make decisions about, what's an appropriate workup, and are they a surgical candidate? And again, as I talked about, we try to, if they are, what's the risk? What's the risk-benefit ratio? I'm a really firm believer in really educating my patients as much as possible. So I try very hard to explain things to them so they understand what the problem is, the nature of their diagnosis, and the nature of the various treatments and what we're trying to achieve. And I think over the years, I've developed a pretty good standardized approach to a lot of those issues, to explaining what the problem is and how we fix these things. At the end of the day, they have to have confidence in you. They have to know that you're going to do the right thing for them. And I believe in talking to patients and spending time with them.
Sure.
So, I don't rush anybody, and I don't, if it means I'm long with one patient and late for the next, I explain that to everyone. Look, everyone gets my time, and we'll get through this. I just think it's, your responsibility to make sure that they really understand what they're getting into, and they have to trust you, and they have to trust your team.
Mm-hmm. Yeah, for sure. No, I've seen that with, like, when I can send people for like interventional radiology procedures, which is, it's sometimes even a little bit more abstract because of the minimally invasive nature of it. And I find it helps when you can explain to them exactly like what they're, in their terms, like what's going on, what's going to happen, what could possibly go wrong. I can tell that, to echo what you're saying, like the patients, they really appreciate it, because not every physician does that, unfortunately, I feel like these days, and
well, there are, and there are constraints. There's a lot of pressure. I gotta, don't underestimate, this too. There's a lot of pressure.
Yeah.
There's time pressure, there's documentation pressure, there's all kinds of loopholes and boxes you gotta check just to get things done. And so that's the downside to medicine. But in cardiac surgery, there's a lot of stress. There's no question. There's a lot of stress, and you have to learn to deal with that.
I guess what's your, like, in your experience, especially like, and how I probably imagine this has probably evolved, since the time you were a resident all the way, till now, but like, what's your way of managing that stress? Because I think, everyone's seen either people who manage it well and people who don't manage it well. And I know you have as well.
Yeah. So I think the first thing for anybody that's involved in like especially where you can get into trouble fast, is to learn. You have to learn to stay calm. It does not help you or the patient or your team to not stay calm. So you have to have confidence in the advantage of staying calm, and that's really important. And you also, by doing that, you increase your odds of success in stressful situations, because if you're not calm, or you're agitated with people on your team, they don't perform well. So we know this. There's a lot of objective evidence of that, a lot of data on that. So you have to stay calm. And when things are really going bad, and there's the possibility of not doing well, you have to really keep your cool. And I suppose it doesn't really help you deal with stress. It's just a way of trying to get through it.
Sure, managing the situation.
And I think that's very important. And you don't always see that. And I've seen cardiac surgical teams that don't function well because the leader of the team is not calm, or is someone that throws a lot of blame, or has a very hostile environment.
Sure.
That used to be acceptable or accepted in surgery in general, and it is not today, I don't think, and it should not be. It's very destructive to have that kind of attitude with in the OR with your team. You have to be a leader and be calm. Work together as a team, and you can see great things accomplished with that. I think too, you have to you have to take time to decompress. Cardiac surgery is both psychologically stressful at times, but is also physically stressful. It's not physically easy because you're standing for a long time, and you're over a table, and you're wearing loops, and your neck can be in particular positions for a long period of time, and you get dehydrated, and so you have to learn to take care of yourself. You have to learn to hydrate. You have to learn to make sure that you have a meal. You have to make sure that before a big case you get some sleep. You have to make sure that you're not overdoing it. When I was younger, I would do stupid things. Like I would be returning from a vacation on one day late in the evening, and I have a big case scheduled next morning. It's like, that's just stupid. Or I'd be leaving town the next day, and I would have a big crazy case. You have to think about those things. Today, and back then too, I might have a case or emergency that came in all night, and I have cases scheduled the next day, and I would do them, and I don't do it anymore. I feel that I'm physically not at my best, I will postpone something. And patients understand this. It's not like we've been up. Our team has been going all night, and you're scheduled for today, but you have a elective case. I would recommend that we postpone, because you want a fresh team. There's no reason to not do that. You make mistakes when you are not rested and fresh.
Sure.
You don't have the resilience. Once you've expended, and you don't know, you might be up all night, and you have a case the next day. It's just a standard, it's a routine 2-vessel bypass, will be fine. But there's always the potential to get into trouble.
Sure. Yeah, I remember you saying that to me. Even with the simplest procedures,
simplest procedure,
anything can totally go to hell.
Go to hell fast. I think I told you that. Been there, bought the T-shirt. You never assume that a case is a chip shot. Never. Always. And so if you expend all your energy, you're not well rested, and you're in what you thought was gonna be a chip shot case, and now it's not. You're not gonna. You may not have that extra strength to really motor through or do your best.
Sure.
So that's something I've learned over the years. And I'm sure I'm older too. I don't have the same kind of strength to do those things as I used to do. But again, this is in the interest of both patient safety and outcomes, and also your own physical and mental health.
Sure.
I would say that there's a lot of concern about burnout amongst physicians. I think the pandemic also highlighted that, and I would say that that's very real. It's very real.
Sure.
You're going to have, if you are in cardiac surgery, if you're contemplating cardiac surgery, you are going to have some bad days. Some days where you can't believe that this has happened.
Yeah.
I've been there, maybe you've done an operation, had to go back for bleeding, and then you find out I got to go back for bleeding again. Same patients, you have problems not fixed.
Sure.
Things like that happen, or someone you thought you did an amazing operation, and you leave the room, and the next thing you know, they're calling you back because they've coded, and you have no idea what's going on, and that kind of stuff happens, and you just have to be prepared for that. So it's it's a different kind of stress than, like, say, interventional cardiology, where they're in jeopardy all the time for having to come in at all hours of the night to do STEMIs.
Sure.
They're on time. They have a time constraint. They have to get reperfusion within 90 minutes, and they may get called in 3 or 4 times in a night or a day, which is a lot.
Yeah.
You come in at midnight, do your thing, go home, and get into bed, and at 2:45 they're calling you back for another one, and you go home. I mean, that's hard. That's not what happens typically in cardiac surgery today. We're not called in a lot for a lot of night work at this point, because patients can be stabilized with intervention, but we have long days and late days, because you cannot leave an operating room until things are right.
Sure.
Everything has to be right. You can't say, well, this is kind of good enough for now. I'm tired, or it's been a long day, we're coming back. It's like, no, it has to. everything has to be working. Heart function has to be appropriate and stable, and there has to be no bleeding. And everything has to be. You when you leave the room, you have to leave knowing that everything is done. And there's a mental aspect of that. I remember when I was younger, you'd finish your bypass grafts and whatever you're doing, and then you would close up. But by the time you're closed up, you're kind of like, you're ready to get done. You want to wrap it up.
Sure.
And you'd be back for bleeding because you weren't careful enough to dry up. So now for years now, our mantra on our team has been, we don't come back. So what we do is we say, as we finish whatever we're doing, the bypasses or the valve, come off pump, decannulated. And now it's our habit, our mantra. At some point, one of us says, we're not coming back, which is our clue, our key, our prompt to take a pause and remember it's not Miller time yet.
Yeah.
So we go, it's like, nope, we're not coming back. And we just dry up, we're just extra careful.
Sure.
And, I think that works. So it's an informal tradition and pause that we have, but I think it actually has some real benefit.
Yeah, sure. No, that makes sense.
Yeah.
What, I guess when you are on call, what are the type of things you would get called in to do? Like where you have to, actually, obviously some of it you can triage over the phone or something, but where you'd actually have to come in and do a case emergently in the middle of the
Well,
day.
someone who is ischemic and there's no PCI option for them.
Okay.
Or there's just a lot of disease that can't be handled with stenting, or failed stenting. Patients who have mechanical complications of infarction, like acute MR, due to chordal or their papillary muscle ruptures, acute aortic dissections, or a surgical emergency. In our system, it's regionalized, so those get transferred up to Cleveland Clinic Main, and we've shown that approach actually results in better outcomes. So instead of having our surgeons like at Akron General or Hillcrest Hospital in Fairview, they're all part of the system, handling 3 or 4 aortic dissections a year. They all go up to Maine. They even with the transfer time delaying somewhat their initial therapy, the outcomes are very, very good.
Oh,
But
interesting.
depending on what your practice is, we get called in for aortic dissections. Those always happen at odd hour. Those always at 2 or 3 in the morning.
Yeah.
And then the other thing that I get called back in for are patients that we operate on who unexpectedly have a bad turn. We see that. They may be fine, and then at 3 in the morning, say, well, he just started putting out a lot of blood. What's happened? I don't know. But we have to go back. And fortunately, that's not common, so we try to handle that up front. So a lot of our cases are what we would categorize as urgent, meaning that there are patients who are in hospital because of a non-ST elevation infarction or other infarction. They can't go home, so they have to be operating while they're in the hospital. And then there are others that are more elective. They're done outpatient, and then occasionally have someone that's truly emergent. But the majority of our practice is not emergent. There's a small percentage. It's what we would call salvage patients that you ought to operate on, but that there's a high chance they're just not going to do well.
Yeah.
We don't do many of those. We try very hard to. When I first started in practice, I think we kind of took everybody. We
just tried it. Yeah.
Just let the chips fall where they may. But today we're much more careful.
Sure.
And we also try very hard. As I said, today it's a much more collaborative approach. Back in the day when I first started, the cardiologist would call and say, "I've got a guy here who's unstable, needs bypass. Come on in, bye." There wasn't much discussion about what are our options here. What's the strategy? What's plan A? What's plan B? Is surgery the only option? Is stenting the only option? Is there a staged approach that might be better? Those are important discussions to have. And fortunately, I work with a really, really, really great team of cardiologists and cardiac surgeons that work together. That's something I would say to someone that's considering going into this and is going to join a practice at some point, is look very carefully at the practice dynamics. Are they really a team? Because if they're not really a team, your life as a surgeon can be pretty miserable. and you're not going to be doing the best for your patients. It helps to be able to collaborate a lot.
Sure. That makes sense.
Yeah.
I think going off that, what's kind of the new like innovations in technology in cardiac surgery? What's kind of like the new, I think you've touched on this with like TAVRs and things like that, but I know
I would say, TAVR is a huge paradigm shift.
Mm-hmm.
So, that was initially technology offered to patients who could not undergo surgery for their aortic valves. And I think it was approached very rationally. We looked at outcomes, and looked at patients who were very high risk. Then we looked at patients who were a moderate risk and even low risk patients. We're finding that technology in appropriately selected patients is not inferior to surgery, and that patients today many patients have an option. Like any other technology, it can be misused. I mean, not every patient who has aortic valve disease should be getting a TAVR valve. A young patient, particularly a young patient who has true bicuspid valve disease, TAVR is really probably not the best option. And certainly a patient that has aortic valve disease and coronary disease, that kind of anatomy, it's not the best option. You want to give them, the most durable operation. And so that's why the heart team approach with that is important. But I will tell you that the availability of that technology has expanded our capability to treat people who are very ill, who previously had no options. So one of the very first patients we did as a TAVR at Akron was an elderly lady. She was in her 80s, I think. She was in acute heart failure with poor heart function, acute kidney failure, very debilitated at that point, other issues, respiratory insufficiency. And the notion, the plan was to make her hospice.
Wow.
She was going to be hospice. And we reviewed her, and we did a balloon valvuloplasty to sort of get her out of trouble, which improved her, again, optimization. Temporarily got her out of failure. It is improved. Made her a good candidate for TAVR. She had a TAVR valve. And when we contacted that lady to see if she would want to be interviewed, for her experience as a TAVR patient, she refused because she was on vacation, didn't have time to deal with us.
That's awesome.
I remember calling her because our what do you call it? Our communications team, wanted to do a story on her because she had been very ill and she was very successfully treated. So they asked me to call her to get her permission. So I called her, and I thought she'd be like, most patients, when you ask them to participate in something, they're very enthusiastic.
Sure.
So I called her and I go, hi, from the TAVR team here. We were wondering if you want to tell your story. It's a great story. Like, hell no. I'm on vacation. I got to go. Bye. And she hung up on me. Yeah, but the point is, that lady was going to be, left in hospice. She would have been dead. And we just did a 91-year-old like that. He's a businessman, retired, super sharp, very sharp guy. Again, was very ill with aortic stenosis. We stabilized him with a balloon valvuloplasty, brought him back in, did a TAVR. He went home the next day. Patients with TAVR go home the next day, typically. Sometimes the same day. I think at the main campus now.
That's amazing.
Wow. Yeah, it's phenomenal technology. It's amazing. And then there's the application of it to what we call valve-in-valve, where patients who had previous bioprosthetic surgical valve or previous TAVR valve, when that valve degenerates, the new valve is put in, again, in a catheter-based fashion, so without a redo sternotomy. And that seems to be very effective as well. So that technology has been a big paradigm shift. I would say, robotic approaches to the mitral valve is also a game changer. I think that the arrhythmia surgery, we now know that there are definite benefits to being aggressive, treating atrial fibrillation surgically at the time of surgery, and there are other less invasive ways to do that. That's been a big benefit, and I would say too that our ability to treat complex aortic disease with catheter-based technologies or combined surgical catheter-based technology. I mean, that's not my specialty at this point, but that's I don't even understand half of what they're doing anymore there.
Mm-hmm.
The guys that do that at like in our aortic team, I mean, the things that they're able to do, people who have just horrible aortic problems, diffuse aortic problems.
Do you see our cardiac surgeons evolving like how vascular surgeons did, where now maybe some of the newer trained surgeons are starting to do more like a mix of open and endovascular type procedures?
Yeah, I do. I think that's naturally going to happen. I think that they talk about the development of what they call cardiovascular specialists as opposed to cardiac surgeons and interventional cardiologists. I think realistically, there will always be a need for someone that is a cardiac surgeon.
Sure.
That can actually operate in an open surgical fashion. I don't think so if you want to be involved in catheter-based techniques, I mean, we are involved, and I think there's probably room to be more involved and to be trained in those skills. But ultimately, I think there will always have to be, if you're truly a cardiac surgeon, you have to be able to operate.
Sure.
And because there are just situations where the disease process is complex or combined, or complications happen. We have TAVR, people that undergo TAVRs where there's rupture of the aortic annulus, and you end up having to open them and replace their valve.
Wow.
Your catheter is not going to help you at that point. You have to be careful. And that's a sticky situation. And that's why in the TAVR realm, cardiac surgeons are an integral part of the team. And so I go, every TAVR is a cardiac surgeon. I go in to help. Normally don't have to do a lot of it with them, but I want to be involved, and I stick around and make sure I'm part of the process until we're sure that there's no problem like tamponade or rupture.
Sure.
Yeah. So yeah, I think the other a big change in cardiac surgery and somewhat of a debate is what's the best way to train a cardiac surgeon today?
Yeah, I was going to ask you about that, kind of like the new, those new integrated pathways versus kind of the more traditional pathway that like what you did. And I think probably still to this day, would you say most cardiac surgeons are probably still trained through that traditional pathway?
I honestly don't know how it shakes out. Okay. I don't know. I do know that we have a lot of medical students who rotate with us, some of whom are very interested in cardiac surgery. I would say that the majority of them seem to be more interested in doing an integrated process. I think probably because it's deemed to be a more direct route to cardiac surgery, and I think potentially because you may actually spend more time doing cardiac surgery.
Sure.
But I think that there's also some debate about how well trained they are, because you have to cardiac surgery is technically difficult.
Sure.
And it takes time to become technically competent. And there are those who would argue that going through a full general surgical training gets people to be good operators.
Sure.
Because
I would imagine like a lot of those skills, even though it's bowel surgery or other types of surgery, like suturing and anastomosis, those are all transferable to doing cardiac surgery. Yeah.
You just have to be, it's even more technically dependent when you get to cardiac surgery. So I could say, for example, that when I did my cardiac surgical training at University of Michigan, I already done 5 years of general surgery residency and 2 years in a cardiac surgical lab doing surgery. And at University of Michigan, one of the big advantages of that program for me was that they believed in having you operate right away. So we operated on we were operating immediately. You were not a bystander. You were on the surgeon's side of the table. But that was predicated on us being able to operate.
Sure.
Now, I think it would be very hard to take someone who's in maybe an integrated program where they have not had much actual operating experience. It begs the question, how does a cardiac surgeon train someone in more basic surgical techniques?
Sure.
Because they're really not, there's not much opportunity in a cardiac surgical case to do that. Sure. Like it's different. Like when you're a general surgeon and they're saying, we're going to take you through a hernia.
Yeah.
You're going to be you'll be doing most of this. And it takes about an hour and a half, however it takes,
Right.
but you can hand over stuff and watch things and you're not going to get in trouble. But in a cardiac operation, what do you hand over to someone that's had a year of training or 2 years of training?
Yeah. No, it's
What are you
fair
gonna,
point.
yeah, what are you going to say? Like, here, you can do this, let me see how let me show you how to do this.
Mm-hmm.
That's just not, particularly, and it's a time sensitive process too. You got to cross clamp on, and you got to check the heart. You don't have time to be taking your time.
Right.
So that's a trick. I think what I've advised medical students who've come my way who are applying, I have advised them to look at every program individually.
Okay.
Look at them individually. Don't assume that you need to be in or want to be in an integrated program or the standard gen surge cardiac surgery approach. Look at them all individually and definitely talk to the residents who are involved in the program and find out, are they operating? Are they really learning to operate?
Mm-hmm.
And that's really important. And are they happy in their program? That's important.
Sure.
You get one shot to learn this. And so you want to be in a program that actually is going to teach you to do it. Because there's the travesty that we've all seen of people who have finished a program who cannot operate.
Right.
Sometimes it's the response, it's a problem with the program, I think, and sometimes a problem with the trainee, and sometimes it's both. But sometimes a program graduates someone that can't operate or shouldn't be operating.
Right.
But so what I tell the medical students to ask is to look at every program, just look at them individually, and definitely talk to the residents and sit them down. They'll tell you. They'll let you know what the truth of the matter is.
Sure.
Are they happy? Are they learning to operate? Are they confident? Do they know what they're doing? Are they treated with respect? Are they supported? I think it was one of the things I loved about training at University of Michigan was the whole raison d'etre of the program was to teach you to operate. You were not there as labor or as a body.
Sure.
You were there to learn. It was an educational program. And so you operate, and we were treated with a lot of respect. We were not, it was not a situation where we were being beaten up. We were treated with great respect. And for that, I owe them a great debt, to teaching me to operate. It's some really great professors there that taught me well.
Sure.
But that being said, I just had a junior partner join me recently who's trained at Cornell, got excellent training, and he brings things to our practice that I was not trained in. And that's something that that I have to deal with at this stage of my career. When I trained, things were very different, and there are things that he's been exposed to that I have no exposure to. But again, it gets to that concept of a team and collaboration. I have a partner who is sharing a lot of stuff with me. I'm sharing my experience with him, and he's sharing stuff with me.
Sure.
And we work together, and it helps us provide great patient care. So, and sometimes I get asked, like, would you do it again? Like, would you?
Yeah.
And I would have to say yes, I would. I think it's an incredibly rewarding career because you do save lives, and you accomplish things in operating that make people better and give them back to their families and allow them to do things. And there's nothing quite like that. I remember, my father was a general surgeon, and he taught me a lot about patient satisfaction. I remember I used to be his driver when he was going on house calls, and he took me I think I've told you this. To a house one night, a guy who was in urinary retention. The poor man was just in excruciating discomfort and pain, and my dad catheterized him and drained his bladder, and the guy was in tears. He was so relieved. And we walked out, and he said, he goes, you see how relieved that guy was, how appreciative he was. And I said, yeah. He goes, there's no amount of money in the world that will give you the feeling that I have right now. I helped that guy out, and that's very gratifying. And he's a very happy man now. He's relieved. So I get this same kind of thing. I think like this morning I had a patient that we saw was post-op day 2, who we talked to her, and she was doing really well. And I said, you did great, And she goes, oh, I'm really happy. She goes, I didn't think I was going to get through this. I was really expecting not to wake up. And I said, well, we expected you to, but that's, she didn't share that with us.
Sure.
But that's how she felt.
Mm-hmm. Wrapping things up here. If someone is like, I guess what I get asked a lot is med students trying to decide, make that big decision on what they're going to go and do. Yeah. If someone's kind of in that, they're in their third year rotations, maybe they're on surgery, they really like it. They do some cardiac cases, they really like it. I guess, what's your advice to people kind of making that big decision? I remember you've provided me with a lot of good advice with that. Like, how do you really do like that self-reflection and that decision process?
Well, one thing that I think you did very well is that you investigated by getting on the ground. You were with many things. I mean, you spent a lot of time in cardiac surgery, you spent a lot of time in research, you spent a lot of time with ortho, you spent a lot of time in radiology. You really got into the weeds and understood what was really going on, what life was like. I think I think that for a medical student who's interested in cardiac surgery, to just have a cursory rotation, maybe a week on the cardiac surgery service during their general surgery rotation is not enough to make any kind of decision. And what I would say is that they should avail themselves of any opportunity, either in their own school or other hospital systems, to do a month of cardiac surgery. That's what I would do. I would find a place. I would do a month of cardiac surgery somewhere as an elective if they can do it. Mm-hmm. The other thing that I found very helpful that probably is not so available today is I did a research elective when I was a medical student at Hopkins in the cardiac surgery lab, where they let me operate on pigs.
Oh wow!
Nella's laughing. So I would operate on pigs, doing cardiac surgical experiments. But I had to do sternotomy. I had to put them on pump, and then do whatever the protocol was. But that and I learned a lot. I wasn't working with any surgeons directly. I was working with some residents and also with an animal research guy. Now today, I don't know how much that's done anymore. Mm-hmm. But it was a great opportunity. I mean, I had to learn to handle instruments and to learn a bit about cardiac anatomy and what bypass, what is cardiopulmonary bypass, how do you do it? Mm-hmm. I just learned an awful lot about that. And I again, in my residency, I took 2 years and did very similar sort of thing, much more intensive animal research work, working with pigs and rat hearts and stuff like that, using different modalities. But those were invaluable operative experiences and taught me an awful lot about cardiac physiology, the physiology of ischemia, the conduct of cardiopulmonary bypass, principles of myocardial protection. There's some ancillary things that you learn from doing that kind of experimental work, and that is resilience and perseverance, because you set up these surgical experiments and things invariably go wrong. Yeah. And start all over again. You just have to, that's one thing that I think that you pick up when you do that kind of work. Sure. And you also learn to question and be skeptical of your initial impressions, because the data often shows that you're lying to yourself about what you think is true. Mm-hmm. Mm-hmm. That's what I would do. I think probably today the most important thing would be getting a dedicated rotation in cardiac surgery.
Sure.
And getting into it. And when they do that, try as hard as possible to function as a member of the team. Mm-hmm. That's important. You have to want to work at this.
Right. Yeah.
I mean, it's great if you know a lot about cardiac physiology and you've read the books and you're book smart and you show up and then you take off at dinner time and you're gone for the day.
Yeah.
Because people know that's not what it's like to be a surgeon.
Sure.
Surgeons leave when the work is done. Mm-hmm. That's just the nature of it.
Right. Right.
And so that's what I would do.
Gotcha. No, I think that's great advice.
Yeah.
I guess to close out here, we ask everybody this: what do you do when you're not doing cardiac surgery?
What do I do?
How do you spend
Let's
your
ask
time?
Noah. You have a question? What do I do when I'm not working? What do I do? What did we do tonight? What did we do?
Play.
What did we play?
We went on a bike ride.
We went on a bike ride.
Nice.
What did we do? What did we do yesterday?
I don't remember.
We played squash, right?
Yeah.
So I play squash. I play with my kids. I ride my bike. I read. I like to travel with my family. We haven't done much since the pandemic started, but a little bit.
Sure.
I like to read history. But I love spending time with my kids. I have 4 kids, and I don't. That's one thing about cardiac surgery is, you're not going to be home at 3 p.m. with your kids. You have to maximize your time with your kids.
Sure. Awesome. Well, Joe, thanks so much for coming on this podcast with us. We really appreciate your insights and your very interesting experiences and sharing that with us. Really appreciate it.
Yeah, my pleasure. It's good to see you. I'm glad I'm so impressed by all the things you've accomplished.
Oh, thank you.
Thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. More episodes are available on our website at dviacademy.com, our YouTube channel. They're also available on Spotify and Apple Podcasts. Also on our website, you can find our video courses for anatomy, biochemistry, and histology, and they're available as month-to-month packages. They're also available as a combo package where you can get all 3 courses in one. Our website also has a store where you can find our outline format textbooks for anatomy, biochemistry, and histology. All textbooks are available in paperback version and as eBooks as well. These textbooks complement our video courses and provide a nice addition to the learning experience of allowing you to focus on the learning and not having to write anything down. On our website, we also provide a free clinical cases video series called DaVinci Cases. DaVinci Cases aims to help you learn how to answer USMLE questions and apply concepts that you learn in our courses to answering those questions. Our cases cover a variety of topics and organ systems, and they're updated frequently with new cases. And then lastly, on our website, you can find our blog, which has interesting articles that cover medical history, important figures in medicine, and innovations in medicine. Again, thank you for listening to this episode of the DaVinci Hour, brought to you by DaVinci Academy. Please be sure to tune in for our next episode.